Ever wondered what atrial fibrillation is and why it's so important to manage it effectively? Atrial fibrillation, often abbreviated as AFib, is a common type of arrhythmia, or irregular heartbeat, where the heart's two upper chambers, the atria, beat chaotically and irregularly, out of coordination with the two lower chambers, the ventricles. This can lead to a multitude of health complications, including stroke and heart failure. It's a condition that affects millions of people worldwide, and its prevalence increases with age, making it a significant public health concern. The Canadian Cardiovascular Society, or CCS, published guidelines in 2012 to aid in the management of AFib, providing a roadmap for treatment. These guidelines are widely respected and followed by healthcare professionals globally. Understanding atrial fibrillation is the first step to managing it. Now, let's delve into the major objectives of its management. The management of atrial fibrillation revolves around four major objectives. Let's unfold this acronym, RACE, to delve deeper into each of these objectives. First up, we have rate control. It's all about controlling the heart rate, making sure it doesn't race too fast or crawl too slow. This can be achieved through medications such as beta blockers, diltiazem, and verapamil. For patients with heart failure, drugs like digoxin and amiodarone can come into play. Next, we move to anticoagulation. The goal here is to prevent blood clots that can lead to stroke. This can be accomplished using anticoagulants like warfarin, dabigatran, rivaroxaban, or apixaban. Our third objective is cardioversion. Now, this is where we try to get the heart back to its regular rhythm. It's typically performed electrically. If atrial fibrillation has been present for less than 24 to 48 hours, cardioversion can usually be performed without anticoagulation. However, if it's been more than that, anticoagulation is required for 3 weeks prior and 4 weeks after cardioversion. In cases where the patient is unstable, cardioversion should be done immediately. The last part of our RACE acronym is etiology. This is the detective part of the process. It's about finding out what's causing the atrial fibrillation. This could be anything from hypertension, coronary artery disease, valvular disease, or even alcohol. It's essential to understand that atrial fibrillation can present in young patients without demonstrable disease, termed lone AFib, and in the elderly without underlying heart disease. With these objectives in mind, the management of atrial fibrillation becomes a systematic process. It's like a roadmap guiding us through the complexities of this condition. Remember, the main goal is to improve the patient's quality of life by preventing stroke and controlling the heart rate and rhythm. Each patient is unique, and their treatment should be too. So, it's all about finding the right combination of rate control, anticoagulation, cardioversion, and understanding the etiology to manage atrial fibrillation effectively. Now that we've covered the main objectives, there are additional management points to consider. Studies of patients with atrial fibrillation, or AFib, suggest there's no difference in long-term survival when treating with a rhythm control versus rate control strategy. However, patients with a significant underlying structural heart lesion, like valve disease or cardiomyopathy, may not tolerate AFib well. These patients should be cardioverted, either chemically or electrically, as soon as possible. Let's now shift to newly discovered AFib. If the patient is at high risk for stroke, anticoagulants may be beneficial. If the episode is self-limited and not associated with severe symptoms, there's no need for antiarrhythmic drugs. If AFib persists, there are two options: rate control and anticoagulation, or cardioversion. These additional points provide a comprehensive approach to managing atrial fibrillation. But what about cases of recurrent or permanent atrial fibrillation? Let's not forget the findings of the AFFIRM trial. When it comes to recurrent or permanent atrial fibrillation, if episodes are brief or minimally symptomatic, antiarrhythmic drugs may be avoided. The focus should be on rate control and anticoagulation. Some patients may remain in atrial fibrillation even after attempts to restore sinus rhythm. In these cases, permanent atrial fibrillation may be accepted with rate control and antithrombotics, as indicated by the patient's CHADS-2 score. Now, let's touch on the AFFIRM trial. This was a randomized, multi-center trial with a mean follow-up of 3.5 years. The study found no difference in mortality or disabling stroke between rate control and rhythm control groups. Interestingly, there were more hospitalization incidents in the rhythm control group. This suggests that rate control was as effective as rhythm control in atrial fibrillation and was better tolerated. This brings us to the end of our discussion on atrial fibrillation management. Remember, proper management can greatly improve patient outcomes. So, what have we learned about managing atrial fibrillation? From stratifying patients using predictive indices to the major objectives of management: rate control, anticoagulation, cardioversion, and understanding etiology. We've also delved into additional points: managing newly discovered AFib and handling recurrent or permanent AFib. The AFFIRM trial highlighted that rate control was as effective as rhythm control in AFib, with fewer hospitalization incidents. With this knowledge, we can all contribute to the effective management of atrial fibrillation. Thank you for joining us today.